First of all, I would like to introduce our panelists. It's Hermann Reichensporner from Hamburg in Germany. It's Hannah Copeland from Indianapolis. It's Kevin Lobdale from Charlotte, US. It's Koichi Toda from Japan. Dave Nakpal from London, Ontario. Nico Brosi from Cleveland Clinic, Florida. And Katie Wood from Newark, Beth Israel. So, our first speaker, and I will introduce speaker by speaker before each presentation. Some housekeeping rules. Please place your questions in the chat. We will organize the panel discussions after all talks together, so no questions after each talk. And we will have an organized, moderated panel discussion. And I will bring up your questions once they have placed into the chat. Our first presenter is Evaldas Gedauskas. He is Chief of Cardiac Surgery in Augsburg and very experienced in the concept of ERAS. And we are looking forward to the talk entitled The General Concept of ERAS in Cardiac Surgery. Welcome, Evaldas.
Hi, Alex, and hey, everybody. Thanks for having me here for this webinar. And my task actually has been to make kind of an introductory talk, a little bit highlighting the general concept of ERAS in cardiac surgery. So first of all, okay, somehow I cannot advance the slides, unfortunately. Okay, now. So first of all, why is ERAS important in cardiac surgery? You know, this list is obviously not meant to be exhaustive, but the issue is still, and the major problem in cardiac surgery is kind of high morbidity. It's not much issue of mortality, but still high morbidity in many of the procedures. It's lack of a rehabilitation and preconditioning before the surgical procedures. Is post-surgical immobilization, lack of a psychosomatic support during the perioperative course, and limited empowerment of patients, having them a passive role in the treatment process. And there is still an issue in interprofessional, intersectoral networking during the perioperative treatment of the patients. The consequences of this, and this is obviously what I think applies in similar way to the end-stage heart failure, which is obviously a major topic, I think, of the webinar today. But the treatment quality is not homogeneous. There is a long in-hospital stay. There are a number of complications due to immobilization after the surgery, and the functional results are still suboptimal. So the concept of ERAS in cardiac surgery, I mean, went through a kind of evolution process, and there are a number of studies already published in the 90s. We start with addressing the fast track concept in cardiac surgery after the surgical procedures, which was basically focused on reduction and shortening of a post-hospital stay, reducing in-hospital immobilization, and expeditory recovery after surgery is not compromising the patient's safety. The focus has been on early extubation and early mobilization after surgery. And there are a lot of studies published over the years after that, refining this concept of fast-track cardiac surgery. However, it was obviously not comprehensive enough to address all the issues during the perioperative course. Another step in development of the ERAS concept has been this one published by an Ancona group, concept of ultra-fast track cardiac surgery by Marco D'Ausenio, who introduced a number of important aspects and components in the ERAS protocol, just trying to reduce the surgical trauma by supporting a minimally invasive access, using minimally invasive extracorporeal circulation, ultra-fast track anesthesia, on-table extubation, and early physiotherapy. However, the whole concept of ERAS developed later on becoming increasingly comprehensive. The focus has been on a fast and complete recovery to pre-surgical state, restitutio ad integrum, and the reduction of perioperative morbidity. The basic principles of enhanced recovery after surgery is the using of an evidence-based and using the best available evidence in the literature, multimodal protocol, including preoperative, intraoperative, postoperative columns of a treatment, and involving all associated professions who are required for this treatment. And then continuous quality improvement by using continuous audit procedures. And I don't want to go through the details because I think that Alex will address many of these things during the next talk. However, the next step in the ERAS development in cardiac surgery has been the guidelines of operative care by ERAS recommendations published in German, which I think was extremely important because they addressed three important steps in the ERAS concept: preoperative, intraoperative, and postoperative management. And these are only a couple of details of them, including the components which have been included due to evidence published in the literature, although their recommendation level is still limited in many of these points, in many of these elements. However, as you may appreciate, the ERAS is obviously a bundle of measures which are important, and it's a kind of cumulative effect, which result finally in improved patient outcome after the cardiac surgery. So if you summarize this development of the ERAS evolution process in the cardiac surgery, the beginning has been a fast-track concept to accelerate recovery, reduce in hospital stay, by early extubation protocols, many variations between institutions. Then it went to the ultra-fast track concept, which included reduction of surgical trauma, ultra-fast track anesthesia, and on-table extubation. And finally, the most comprehensive concept is the ERAS concept, which focus on evidence-based and standardized care after the cardiac surgery, improving an interprofessional and intersectoral principles of care. So I would like to show you a couple of details because I have been involved in ERAS protocols in cardiac surgery since 7 years, being then in Hamburg at the University Hospital together with Hermann Reichensporner. We started the ERAS program there, and I moved later on 2021 and to Augsburg, becoming a chief of cardiac surgery there. And we started to introduce this protocol in a minimally invasive cardiac surgical procedures. And over the time, we developed to the all-comers approach. And we only exclude patients who undergo emergency procedures and some high-risk individual cases. By now, more than 600 patients have been treated using standardized ERAS protocol, and we are expanding the spectrum of ERAS program to going towards the patients who undergo a complete sternotomy, which is obviously may be relevant for developing the ERAS protocols in the end-stage heart failure. I think the important thing in the implementation of the ERAS in a new institution which has no experience with the ERAS until 2021 has been an increased trial, which is actually the first randomized trial performed in 2 institutions in Germany, in Hamburg University Heart Center and in Augsburg University Hospital, which basically compares in a prospective randomized fashion the ERAS versus standard of care in patients undergoing elective minimally invasive heart valve surgery, randomizing in 1-to-1 fashion to the ERAS intervention group and a control group. A total of 200 patients have been recruited for this trial, and the project was finalized in July this year, and results are to be presented in Q4 2024. So by introducing these protocols, you should be aware of the fact that many of the components of perioperative care are addressed during the ERAS introduction process. And there's only a couple of them here. I think from my point of view, most important if you're trying to to introduce a kind of protocol of your institution, and thinking about expansion of this protocol to terminal heart failure. And here's a couple of elements during the preoperative, intraoperative, and postoperative course, which I found most important, I think, for the success and for introduction of the ERAS protocols. So what are the factors of success? Because I think the introduction of ERAS is the first step, but the most important, most difficult part of this process is the maintenance of the ERAS program. It's a kind of continuous process. And one of the major challenges, and I think, and one of the major key factors in the maintenance of a kind of an ERAS network in the institution is this interprofessional and intersectoral network, which has to be established and has to be maintained. And there's a lot of interface management between these professional groups involved in the ERAS management. And from our experience, I strongly believe that a kind of central coordinator in terms of an ERAS nurse are extremely important for this coordination of the processes in the hospital and actually outside the hospital, including the rehabilitation hospitals, where general physicians and outpatient cardiologists. So from my point of view, it's really a key player in this process. And another thing, I think, which is very important when you're trying to maintain this continuous project, which functions as long as you are always keeping on motivating the people and keeping involving the people, I think, is that ERAS has to be present in your daily clinical practice. And this is, I found, an extremely important point by motivating the professional groups involved and trying to involve them and to motivate them to work together in this interprofessional group. And this is something I think we have to think about when you are introducing these protocols and expanding these protocols to the patients with end-stage heart failure. So at this point, I would like to finalize my presentation, and happy to answer your questions at the end of the webinar.
Thank you very much, Evaldas, for this very nice overview and impressive work you have done so far. So
Yeah.
maybe some housekeeping rules at this point. Please mute your micros because we are recording the session here, and we will answer these questions during our panel discussion at the very end for those who came later. The next speaker is Alex Gregory from Cummings School of Medicine and Living Cardiovascular Institute, University of Calgary in Canada. He will give us a talk on the ERAS Society and future direction of ERAS. Thank you very much, Alex, for being here and accepting our invitation, and we're looking forward to your presentation.
Wonderful. I guess it's good afternoon for you. Good morning for me. Thank you for the invitation. And I'm joined by Dr. Lobdell, who's also a member of our ERAS Cardiac Society. So we're very pleased to join with you in this webinar. Evaldas, thank you for that very excellent first talk, outlining some of the topics related to and elements related to enhanced recovery. So my job this morning is I'm going to start talking a bit about what the ERAS Cardiac Society does, and then also some of the future directions of perioperative care. So before I get started on what we do and where I think the future lies, I think it's important to think about enhanced recovery within a framework of some of the key pillars that guide us as we moved along this movement. You could debate there should be more or less, or which ones they are. These were the 8 that I've come up with that I think we use to guide as a society, as a society, but even as individuals and institutions that are pursuing enhanced recovery. So I think by far the most important, of course, is the patient, and remembering that this is all about optimizing the patient recovery and the patient perspective on their recovery following surgery. I think we can never lose the importance of science. You know, we want enhanced recovery to be about evidence and not about opinion or dogma or whatever, or what you think is the right thing to do. And so we're always trying to have the best evidence and the best science guide us. We talk about inclusivity. So when you have trying to look after somebody through all phases of care and in all aspects of their care, it really does require a team approach and a multidisciplinary team approach. So I think the key to enhanced recovery success is, as I've mentioned, it's everybody and every part of the team that will make you successful. Nurses, physicians, all healthcare providers. Another lesson that we've learned is the importance of implementation science. So it's a lot easier to come up with the protocol and have elements and think you know what you would like to do than it is to actually have that work in your hospital. And so we've really learned the importance of some of the key aspects of implementation science and how to initiate and maintain organizational change. Part of that does include education, which I've listed here as well. It's important that we educate ourselves and educate those that maybe have less familiarity with ERAS, but also within people that have familiarity and experience, continuing to learn from each other. I do think that enhanced recovery is always going to be iterative. We're always going to be chasing innovation and better ways to do things. This, of course, leads to improved quality and improved safety for the patients. And finally, when you bundle this all together, the idea is that we achieve value, and that's value for our patients and value for our healthcare systems. So the ERAS Society, what are we currently doing? So as Valdis mentioned, we formed as a group in about 2017, 2018, and our first publication was 2019 in the JAMA Surgery. We had done some guidelines. And so we kind of worked over the next few years disseminating that knowledge. And then this last year, what we did was a second iteration of these recommendations. And so this was just published this past spring. The link is here at the bottom. And this was a joint effort with our parent ERAS Society, as well as the Society of Thoracic Surgeons, to create this expert consensus document. And what I've done on this table is I've outlined there's 24 elements that were in this recent expert consensus document. And what I've done is I've also put elements from the JAMA 2019 document on the left and grayed out the elements that were not previously included. And I've done this really to highlight how in our second iteration, we've really grown and evolved, and I think taken more of a perioperative perspective. So it's kind of changed from, I think, the original enhanced recovery style. And I've highlighted a few here that I think demonstrate some of that evolution. So one of the things I like to point out is how we've now added things like establishing a multidisciplinary team, or having early ambulation and exercise. So these are very non-MD, non-physician type elements. And so we're really trying to show here how it really is a team effort that is required. I'd like to also point out that we've really developed a more comprehensive approach at organ injury and organ protection. So things that were not previously included on our original, such as CNS monitoring, lung protection, blood management, atrial fibrillation. So we've really tried to grow the different organ systems that are now involved. And then finally, you'll see that there's actually inclusion of more patient-specific things on here, such as including patient engagement. But I like the fact that we included post-op nausea vomiting, because I think that's something that we often can minimize as its importance. But if you actually talk to patients, that's one of the most important things that affects their recovery from their perspective. So I think we've really tried to develop a more modern and comprehensive expert consensus document. And this hopefully provides lists of elements for institutions to use when they're trying to develop their own program. Another initiative that we've taken, and I'll leave this screen up so that people have a chance to use the QRs if they so choose, is we found when discussing with people, there is often a challenge of taking the evidence that exists and then turning that into an actionable order set that they could use at their institution. So what we did as a society was we went and looked through existing guidelines on various topics. And then from those guidelines, we extracted recommendations that had high level of evidence or those that had medium level of evidence. And they created order sets that organized it by things that you should probably do because they have high evidence and things that you could consider doing because they have moderate evidence, and then turn them into order sets that would be amenable even to using an EMR like Epic or another EMR. So for us, this was that implementation science aspect where we really wanted to try and help people get from guidelines to bedside easily. So those are a couple of things that we've been working on. So then I guess that leads us to the future and where do we really go from here? Now, there's a lot of things that we can do. Of course, enhanced recovery never really stops. This was an editorial that a group of anesthesiologists and intensivists internationally wrote in response to the expert consensus document. And it sort of outlined some key areas and included things like, again, focusing on patients, focusing on organ protection and injury, focusing on saving people or recovery, also artificial intelligence, so various areas that we thought were interesting elements for the future direction. If I was to try to distill that editorial, but even just discussions that we have had as a society or that we've had with our collaborators outside of our society, my personal top three on this is that first, I still think we need to continue focusing on patients. You know, we talk about patient-reported outcomes. We try to talk about having patients involved, but I think there's still a lot of ways to go. Locally, we're just finishing up a systematic review on patient-reported outcomes in cardiac surgery, and there's over 30 different tools used and used by different people and used in different fashions. So we don't even have consensus yet on how to report the patient perspective. And so even simple things like that we need to do. The second one is to continue to develop evidence. If you recall in that table that I showed with the expert consensus document, about 18 or 19 of those elements have only moderate or low evidence. So we have a lot of room to go in terms of for each element demonstrating evidence, but also demonstrating evidence for enhanced recovery as a whole. And I think it's very exciting. I know a lot of the speakers today are presenting some data. Evalus already has shown that their study is currently ongoing. And I foresee in the next year or two that we'll start to see a lot of publications on the actual science and evidence of enhanced recovery. And that's very exciting. And we need to continue to support that and foster that. And then finally, I really think it will be important for us to think of ERAS as something for all cardiac surgery patients. And that's why I'm particularly happy that we got to come to today's webinar, because I think traditionally a lot of people thought of enhanced recovery in cardiac surgery as something to give to the healthy CABG patients. You can get them out of hospital in 4 or 5 days. And I'm not saying we shouldn't do that, but we have other patients that are much more complex, much sicker, that have more complicated surgeries that are happening, and they too will benefit from the principles of ERAS, which is standardized care, holistic care, multidisciplinary involvement. So I think it's time for us to try to look at how to use ERAS in every single cardiac surgery patient. I'll conclude at that. This is the website for our organization. We do have some additional educational content on there that you can link to through this QRS code. Other than that, again, thank you, and I look forward to being part of the panel today.
Thank you, Alex, for this very excellent talk. And I think with both of these talks, we have a very good basis and to go into the panel discussion how we can advance these ERA protocols in advanced heart and lung failure. And we know a little bit more specific on these topics. And it's our great pleasure to have Igor Gossev from Newark Beth Israel Medical Center, Newark, with us, and he will present on ERAS in left ventricular assist device surgery. Igor. Igor, we can't hear you, or I cannot hear you.
I'm sorry. Hi. So I hope you guys can hear me now. I know you can hear me now. Sorry. It's a pleasure to be here today. Evaldas and Alex really got a great intro into this very important topic for the future of medicine. You know, I think I'm glad that Alex threw this softball that all cardiac surgery patients need to have, a concept of ERAS involved in their care. I've recently moved to Newark Beth Israel, but for the last 6 years, we worked. Oh, For last 6 years, Kate Wood and I have been working with a team in Rochester on creating an ERAS for LVAD. We wanted to expand that to our whole advanced heart failure portfolio, and eventually we included our heart transplant patients as well. So I'm actually very honored to be able to share some of our initial data and some of our initial concepts, not necessarily data, with the rest of you. This ERAS process obviously started, as we know, in colorectal and kind of more streamlined surgeries. Both Evaldas and Alex talked about that. I'll skip that part. But our initial cardiac surgery experiences showed improved outcomes, decreases length of stay, decreased ICU length of stay, and overall better patient and provider satisfaction. Alex also talked about the guidelines. We've implemented all these guidelines in our ERAS process for LVADs, and that resulted after a good year or so of work in our publication that involved, after our initial 1-year experience, involved multidisciplinary team. And we have here kind of highlighted different colors, different people from our team from different specialties. So blue, they're anesthesiologists. The green people like Karen Chase, Neil Kumar, they are intensivists. Our red highlighted team members are Hema and Jeffrey. They were heart failure cardiology doctors. We have our BAD coordinators, Chrissy Cheney. We have different team members that participated in building this complex process. Our initial paper and our initial protocol showed 5-fold decrease in our opioid prescription and discharge, showed decreased bleeding and blood product transfusion, and increased our discharge to rehabs home compared to rehab, or decreased our discharge to rehab from 20 to 2.4%. And how did we achieve that? Well, it's this big team effort that involved a lot of team building that I think included coordinators. Now, initially, as we started, we have multiple people kind of leading their part of our ERAS protocol. So we have preoperative, intraoperative part. Between us surgeons, we really standardized everything within the OR, so the process can be the same. Our process involves less invasive implants of LVADs, which kind of was a nice intro into the whole process. But it was building a team that is committed to improve patient outcomes. And then we've recruited champions, as I said, in every aspect of care. For heart failure team, there were a lot of questions because process is not as straightforward, and there are always the questions like, do we have to document this? We have a couple of places that we need to do that at. This is just another thing to do, and I think it was important that we've created an overall understanding of importance of standardization, and over time, I think we've done that. This slide, in theory of marginal gains, it was introduced by Kate Wood to me, and she has spoken about this extensively. But I find it really important because it applies to everything from athletics, music to medicine, and it kind of shows importance of tiny daily improvements that create a big difference over time. It points out that the consistency and kind of grit in pursuing the protocol eventually pays out. So key to success, 4 things: standardization, education, champions, and auditing. At Rochester, we created standard of care and best practices across the whole patient experience. I think it was important to show that every detail matters. And, this broken window theory really was important for the whole heart failure team. This shows the complexity of care between the four aspects of a patient journey through the hospital. So we have different team members participating in a different aspect. So, preoperatively, obviously, we have majority of the teams pitching in. Intraoperatively, we have cardiac anesthesia, our surgical team, and nursing cardiac care really taking over. And then, postoperatively, our education, our intensivist, and our floor team really took over. But it shows the complexity and the extent of this endeavor. These are the kind of separate highlights of each of these aspects of care. They really reflect the majority of ERA's recommendations. We've tried to implement all of them. So I will not necessarily go over all of them, but we do pay close attention to every aspect. This is something. This is kind of a visual presentation of the same thing that was done by ERAS Society. Similar, we've kind of embraced it and did the same thing for our LVAD patients. This type of brochures and posters were shared all across the hospital, and each team member had ability to kind of understand the ERAS, understand where his or her patient is on this trajectory, and it really certainly improved our implementation. Quickly, going through the process, prehabilitation, obviously one of the key components, and standardizing prehabilitation for VAD patients was critical. For us, a lot of these patients are in hospital. They're all very sick. We see it as basically a training camp that can last anywhere between 2 to 4 weeks before LVAD implant or heart transplant. That involves, all the aspects of care, like physical activity, improving nutrition. We're working on anemia resolution, obviously smoking and alcohol, and drug cessation counseling. One of the very important things, especially for older patients, is swallowing, and for everybody, breathing exercises, but specifically for our older heart failure patients, are swallowing and breathing exercises. As a lot of these patients have problems and issues after surgery, after they get extubated. Obviously, all of them are getting education on their therapy and on the meds and the process they'll encounter after surgery. And then obviously hemodynamic optimization or volume optimization. So, part of physical activity that obviously decreases sympathetic overactivity. It increased the ratio of lean body mass to body fat, and improves insulin sensitivity. It is multidisciplinary planning. Everybody that touches the patient basically are responsible for supporting this process. But important parts are actually activity boards that we found really help with our heart failure patients. Having these scheduled exercises and making sure that all the tests and any other additional things that need to happen around this process. Hemodynamic optimization, I think it's fairly clear, but it includes diuresis, inotropic support, PA catheter guided decisions, and temporary MCS if needed. I'm gonna speed up through some of these processes a little bit, but these are standard protocols or standard parts of the protocol that ERAS recommends. And in interest of time, I will skip through them to get to the team engagement and team effort in implementing ERAS. This is a picture from our first less invasive surgery, and it certainly involved our less invasive surgeons, our VAD surgeons, Dr. Wood, myself, and our chief at that time. Post-operatively, multimodal analgesia. Obviously, we do bilateral thoracotomy LVADs. These unfortunately have initial significant pain that we really take care of with our multimodal approach, plus pain blocks and in recent years cryoablation of the nerves. So at Rochester, we developed our checklists in Epic for ICU and for the floor. Those checklists really helped us standardize our rounding. It helped us improve throughput, decrease chances of missing things, and certainly increase the provider satisfaction. This aspect also very important, but all throughout the patient course, obviously microlearning and patient education initiatives really happen. So by the time they're ready to go home, they already know everything they need to know about the LVADs. And at the end, we would not be able to do all these things without subspecialty champions. They're listed here, and I think important part of ERAS protocol is asking their opinion and implementing their protocols in a larger ERAS protocol for heart failure. At the end, you want to celebrate your achievements, make sure your team understands how and why you're doing it, and how your patients are doing it overall. Thank you.
Thank you, Igor, for this impressive protocols you have implemented, and we will come to that during the panel discussion for sure. So we stuck a bit with the MCS topic, and as you all know, ISHLT is organized by IDNs, and so we try to cover not only durable VADs, but also acute cardiogenic shock and temporary mechanical circulatory support. And as one of the leaders in this field, we have Evgeny Potter, Prof. from German Heart Center, Deutsches Herzzentrum of the Charité in Berlin, and he will present the Berlin experience with Impella 5.5 implantation under local anesthesia.
Hi, Alexander, thank you very much for the kind introduction, and I will show you very interesting data. What we do now, we try to be far away from theoretical medicine and instead to put every pieces together and present nice slides. We just do ERAS, and one particular point of the ERAS is implantation of Impella 5.5 under local anesthesia. We started to do it last year. Now we have experience of 1 year of implantation under local anesthesia, and I will show you some details. So this slide shows you that in the coming guidelines for temporary MCS, which will be published next year, in this guideline, microaxial flow pump, MFP, plays a central role in the treatment of patients in cardiogenic shock, independently of myocardial infarction or non-acute myocardial infarction. So the Impella is an end or combination with ECMO. So, and I show you how to implant Impella in the local anesthesia. You see here, the important is the preparation of the patient. The patient's on the table, anesthesiologist is there. And as we can see, we use transthoracic echocardiography parasternal view. So the dressing of the patients are very important. So we dress only this part of their chest on the right side. And so it's much easier to perform on the left side transthoracic echocardiography and on the right side implantation of their pump. So we will be a little bit faster. So you see here the dressing. Only the necessary part of the chest will be sterile dressed. The patient is awake, as you can see. You see they're a little bit skeptical anesthesiologist because to perform transthoracic echocardiography, it's not that easy for him because they do not have experience. So I do it by myself if necessary. And now, after 1 year, all of our anesthesiologists, they may perform transthoracic echocardiography. It is very easy to learn. It is just parasternal view, and it is. So as you can see, I start to cut the patients as extubated, still extubated. On the right side, you see no tubus, nothing. And we perform this in a local anesthesia using 20 milliliters of silocaine. And we did try with scalenus blockage, but it does not work. So I do not recommend scalenus blockage. And you see here echocardiography performed, transthoracic parasternal view. So you see introduction of the impella and also echocardiography under echocardiography and X-ray control. So this is, you see here the echocardiography and X-ray, both of them are used. Okay, this is how to do it, and it's also possible to implant ECMILLA because if you use a Y graft, single arterial access, you are able to implant arterial line in the Y graft through the same approach, and venous cannula through jugular or femoral vein. So this is our result. We started last year in January, and we have now 34 patients implanted in local anesthesia with different kinds of sedation. This is really up to anesthesiologists. Remifentanil, dexamethasone, or midazolam, sometimes in combination, and the distribution age is as usual in our patients, and 76% male. You can see that majority of the patients are in SCAI-C, 70%, and 21% in SCAI-D. So majority of the patients are in cardiogenic shock. Some of them are implanted for as a protected PCI or for example, protected CABG, or for preconditioning, but majority again, 91% of our patients are in severe cardiogenic shock. Median WIS was 12 and with elevated lactate. And in 1/4 of patients, ECMILLA was implanted in this approach. So in the local anesthesia, 24% of ECMILLA. Majority of them, of course, right axillary artery. And 2 patients required conversion to general anesthesia due to respiratory issue. And majority of the patients could be mobilized the next day. Most of these surgeries are in the night. So in the morning, the patients are mobilized on the bed and could walk. So what to do after impella implantation? So these patients, if they are candidate for durable device, they receive durable device. This is impella weaning protocol adopted in our institution. It also will be published as a part of the AATS, STS, and ASCTS guideline. So what's about durable LVAD? Of course, it's a much more better for the patients to be not to be intubated and get full LVAD. You imagine Impella 5.5 pumps 5.5 liters, so it's a full support LVAD implanted in the local anesthesia. And what happens to these patients if they are transferred to durable devices? We compare patients who are transferred from Impella to durable device, the red box, compared to the green box, patients with Intermax 3 and 4 transferred to durable devices. This paper will be presented next month in October, or next week in Lisbon. So, and the results is very important. Here we have patients who has been in cardiogenic shock and supported with Impella, prepared for durable device implantation, and you see the results. The results are the same. The survival is completely the same in these 2 groups of patients. And their complications are much less in this approach. And however, there are some more renal failure in patients supported with Impella, but it's a preoperative high risk of renal. They are in shock, so they bring their renal failure already into this group. So it is should be really differentiated. They came already with renal failure, or it's caused by Impella. So if we differentiate this, that's much less renal failure in patients we supported with Impella. And what we achieve in this with this approach, you see the yellow box. It's a very important. Pay attention to the yellow box. Yellow box, especially Intermax 2. If you compare with 10 years ago, we have almost 50% of the patients supported with durable devices Intermax 2. So unstable patients should be implanted right now. And now we have less than 10%. So it is this is our goal, to eliminate this yellow box to zero. In conclusion, awake Impella or ICMELA implantation is feasible and safe procedure, and transthoracic echocardiography is a reliable tool for Impella or ICMELA location during awake Impella implantation. Thank you very much for your attention.
Thank you, Evgeny, for this impressive results and this concept you brought here into this field. And we go on with Constanze Volkmann. She is resident in our institution, and she will present our concept, which we developed with Evaldas and Hermann Reichensporner in our institution, and give some insights how we do it with heart transplant recipients.
Thank you. Thank you very much. It's really my pleasure to be here today, especially as an early career member, and be able to talk about the errors in heart transplant surgery and our experience with the implementation of ERAS protocols in our transplant center. ERAS protocols have gained increasing importance in the recent years, and we've all become really familiar with implementing those protocols in our patients undergoing cardiac surgery. And initially, those protocols have been used for relatively minor procedures, but gradually this has increased to be used in major procedures as well. Main features of the ERAS protocols, as we heard already, are interdisciplinary and multimodal patient management, aiming to promote an early patient recovery by reducing the stress response to the surgery itself, but also to accelerate postoperative recovery, decrease the length of hospital stay, and therefore decrease post-op morbidity and mortality. But when we look at our heart transplant recipients, we have patients that are in lots of ways different from the normal patients population that we have undergoing cardiac surgery. And therefore, those patients present a few special aspects when it comes to ERAS protocols. First of all, those patients suffer from advanced heart failure, meaning they are often hospitalized for a longer period of time, for example, on heart failure units, or even the ICU during their waiting times. And most of those patients are listed with hypoperfusion syndrome if they're listed in high urgency status, meaning they present with cardiac decompensation, inotrope dependence, and organ failure, for example, renal failure, congestion, and they're really limited in their physical ability to exercise. On the other hand, we have patients which are listed with LVAD complications. They often have driveline or device infections, leading to systemic infections that are in need of antimicrobial treatment. And a lot of those patients have prior cardiac surgeries, and that results in the transplant procedure being a reoperation, complex reoperations, and sometimes even the second or the third sternotomy for the patient. And lastly, which is also an important aspect, is that transplants are no elective surgeries. So the planning of the transplants can be difficult. And I know there's a difference between the US and Germany, but we have patients that are listed as transplantable and not high urgent. And those patients are often at home and they are not necessarily at the hospital. So that makes it difficult for us, or the patients are not that accessible, for example, for prehabilitation measures. And all of those factors make it somewhat more challenging to have an ERAS protocol for those patients listed for heart transplantation. But still, we do want to include those patients in our ERAS program. So we have implemented ERAS protocols, so enhanced recovery after cardiac transplant surgery, roughly 4 years ago at our center, and divided those into several perioperative bundles. And we're starting from the preoperative or prehabilitation bundle, which focuses on the optimization of patient-related factors, to the intraoperative bundles with the adjustment of the anesthesia protocol to a fast-track anesthesia, and to an adjustment of the cardiopulmonary bypass management in terms of goal-directed perfusion. And lastly, the post-operative rehabilitation bundle, focusing on the promotion of the patient's recovery. I'm going to present just some aspects of each bundle. The protocols, of course, are more detailed. The prehabilitation bundle consists of basically physical therapy and exercise, even during the waiting list time, especially also if the patient is inotrope dependent. And those patients often wait for several months on the heart failure unit. So this has become a pretty important aspect. And as well as the optimization of the preoperative medication, and also physical interaction of those patients waiting for several months. We have planned activities, for example, dinners or the exercises. They do it in groups. Nutritional optimization is an aspect, and especially for the LVAD patients, the infection control becomes increasingly important. Before the transplant, we have driveline infections, antimicrobial treatments, which are established in interdisciplinary endocarditis boards. And if there are extensive driveline infections, we have VAC therapy and a weekly wound debridement or dressing of the wound. When it comes to the anesthesia protocols, it's focused mainly on the minimization of opioid usage, and these following drugs are used for the induction and the maintenance of anesthesia, but also the lung protective ventilation and goal-directed, or rather restrictive fluid management, as well as temperature regulation. And here, mostly important, the avoidance of post-operative hypothermia, and the minimalization of blood transfusion is really important. So we're using cell savers that the patients can be retransfused with their own blood cells, and every patient gets continuous neuromonitoring. When it comes to cardiopulmonary bypass management, traditionally, the blood flow rates were calculated with a formula that was correlating cardiac index with the body surface area. And this is rather a general approach and not really taking the individual patient into account. So to ensure an adequate blood flow to the organs, our standard nowadays is goal-directed perfusion with an individualized targeted delivery of oxygen and consumption. This makes the measurements of additional metabolic parameters as oxygen delivery, extraction and consumption, as well as carbon dioxide production and lactates levels necessary. And furthermore, the goal-directed perfusion can also reduce post-operative acute kidney injury, which is favorable for this kind of transplant patients. The last bundle is the rehabilitation. We aim to achieve an early extubation on ICU, followed by immediate respiratory exercise, early removal of all catheters that are not needed anymore, central lines, drains, ensuring of freedom of pain to promote that mobilization and this respiratory exercise. Delia screening and prevention and early oral intake are also important factors on ICU already. And as soon as the patient is stable enough, we transfer them back to a heart failure unit where we continue all of the above mentioned measures and also with daily physical therapy and respiratory exercise, and we promote early recovery and discharge to a rehab facility. After the implementation of those ARIS protocols in November 2019, we've already heard from Evaldas that we've established those protocols in minimally invasive valve surgery already. We conducted a small retrospective single-center study to evaluate the early outcome in our recipients. And here you see the outline. We compared baselines and perioperative parameters, complications, and outcome in a total of 102 patients, dividing them in two groups, one group before the AREX era and one with the AREX protocol. And we ended up with almost equal patient numbers. Primary endpoint was 30-day survival, and secondary endpoints were, for example, ICU and hospital length of stay, time to extubation, stroke, PGD, MCS, renal replacement therapy, or 1-year survival. I'm just quickly going to go through the results. They are preliminary data, so they're not published yet. But we see that the baselines, both groups were similar in age, sex, and the underlying cardiomyopathy. We also have 37% of VAD patients in both groups, and between 53 to 63% of the patients had a history of prior cardiac surgery. And in the perioperative parameters, it showed a significant difference regarding extracorporeal circulation and reperfusion times, with shorter times in the AREX group. That was too fast. If we look at the post-operative parameters, we see an overall lower lactate level in the AREX group and lower rate of renal replacement therapy post-transplant. And the occurrence of severe primary graft dysfunction and ventilation times only showed a trend. 30-day survival rates were equal in both groups with 96%. If we look at the 1-year survival curve, we see both groups show also equal long-term outcome with survival rates of 88.7% in the AREX group and 91.8% in the pre-AREX group. And therefore, I would like to conclude that our AREX protocols include the bundling of pre, intra, and post-operative management and treatments. And those patients who underwent heart transplantation using our AREX protocols showed shorter extracorporeal circulation and reperfusion times, lower lactate levels, and a lower rate of renal replacement therapy. And after the implantation of the AREX protocol, the patients showed trends towards shorter ventilation times and lower rate of PGD. And therefore, we find the establishment of AREX protocols, even in those high-risk patients and complex patients undergoing heart transplantation, as a feasible and safe strategy, and it can potentially further improve their outcome. Thank you very much.
Thank you for Constanze for presenting our protocol and data, and I'm sure there will be questions during the panel discussion at the very end. So we do not only want to cover cardiac aspects here into our webinar regarding ERAS protocols, but would also like to cover the topic of lung transplantation and lung failure. So we have the great pleasure to have Julien Fessler with us. He is from Hospital Foch in Suresnes in France, and he will give the talk of ERAS in lung transplant surgery. Julien, you're still muted. Yeah.
Yes. Okay, let's go. Thank you very much for the invitation to this challenge to discuss enhanced recovery after lung transplantation in only 10 minutes. So I have a conflict of interest with General Electrics, but nothing regarding this presentation. Just to introduce the concepts, now I would like to present the evolution. We use a machine learning technique to assess the risk of primary graft dysfunction 3 days after the lung transplantation. And here you have the different stage of the surgery. And you observe here from stage 6 to stage 7 that there's a huge increase in AUC in the prediction of the primary graft dysfunction. So that means that something arrived around this aspect of the surgery from 6, 7, and 8. And that's after the first lung implantation. First lung implantation is stage 6, and then step 7 is the second pulmonary artery clamping. So that means that there's something in the relation between the host and the graft. And if we look into the microcirculation, we observe that blood lactate is something very important. And then in the study that we published in JCVA 2 years ago, we observed that there's the difference in pattern of blood lactate level evolution between patient developing a primary graft dysfunction 3 days after surgery from those who don't. And we also observe that blood lactate level increase very much after a certain stage. Well, but why I want to talk about that? So just to show that there are two kinds of people. The very severe patient with a high rate of mortality. So that's a study where we extubated patient in the OR, and we observed that the patient not able to be extubated in the OR had a more difficult journey during the first days after surgery with a higher mortality rate. And those who could be extubated had a very simple journey with a normal way after lung transplantation during the first year. So that's to introduce that maybe we have some patient where we can maybe implement ERAS. And then again, what is fascinating with lung transplantation is that it's across different kind of specialty. ICU with the understanding of metabolism, sepsis, and immunosuppression. Cardiac surgery with the dealing of complex coagulopathy, transesophageal echocardiography, mechanical circulation support, or pulmonary hypertension. But also thoracic surgery because of one lung ventilation, protective ventilation, regional analgesia, and end-stage lung disease. So what if we try to pick one of these aspects on the cardiac ERAS and the thoracic ERAS, and we implement it to lung transplantation and maybe targeting some patients? So we're going to develop now the 3 different aspects from the preoperative, intraoperative, and the postoperative management. And we'll discuss first frailty. And there's some interesting study on the specific assessment of frailty assessment preoperative to the patient. And we observe that the specific scores for lung transplantation are associated with waiting list disability and delisting and death, but also on health-related quality of life. And we could observe on the different kind of assessing this specific lung transplant frailty scale that it was associated to 1 year mortality. So maybe we could use this kind of tools to assess the patient and then maybe to send them for rehabilitation. And we see here in this virtual physical rehabilitation program, sorry, my son is crying, in this study from Montreal that 12 weeks prioritization from using virtual tools that are maybe easier to perform when patients come from very far from the hospital, that we haven't improved in the strength, in the functional status, and the frailty. So second aspect we can develop is patient blood management in the nutritional deficiencies such as iron, copper, or vitamins that makes the patient being anemic, but also in the vitamin K that would be related with coagulopathy. Then we can also have a coagulopathy in patient under preoperative ECMO. And then we have other kind of bleeding associated factors such as the ECMO management, the heparin, and the incision. But also related to the transfusion, we have also to discuss the threshold for transfusion, because some teams are still at 10 gram per liter, but other to only 8. So maybe something to discuss. And finally, we need more studies to assess the use of viscoelastic test in lung transplantation. Regarding the intraoperative management, mini-invasive surgery, two teams have published the use of robotic surgery to perform lung transplantation. There's a nice syringe HLT from California with 8 patients, and then another one from Barcelona. A different kind of approach. Maybe it's not appropriate to all kind of patients, but the thing of it's important to start thinking of more mini-invasive approach, improving the kind of techniques. But I won't discuss that much more. But it's something that we should develop to reduce the stress induced by the surgery. Then optimal anesthesia. Optimal anesthesia, it was very nice, published in a nice editorial during the last century by Paul Miles, use of short-acting drugs, normothermia, goal-directed fluid support, an effective analgesia, and non-invasive, systematic non-invasive ventilation after extubation. We're going to go a little bit deeper after regarding these aspects. Then ECMO. ECMO is a highly debated subject in lung transplantation. ECMO to everyone, ECMO to the minimum people, ECMO on selective criteria. Well, that's a huge retrospective cohort where they found that off-pump had a better outcome than patient undergoing on systematic ECMO or CBP. But to really answer the question, we need RCTs. And today there are 3 RCTs ongoing, and that's the most interesting one. It's built by the Montreal team again. It's systematic versus on-demand ECMO based on 5 criteria. They study in a preliminary study, and they try to to build a study in real life, in real conditions, and that's the real question that we ask ourselves during every transplantation in order to implant or not an ECMO. And they did a very serious calculation, and I think it's very important to highlight how honest they are, because they declare 310 patients per arm, and that's really enthusiastic, but maybe that's what we need to answer. Then regarding the postoperative aspect, early extubation, early removal of the drain and the lines, early oral feeding, early mobilization, delirium. Well, that's the standard proposition in the different guidelines from the ERAS in the heart or in the thoracic surgery. But I want to show you this picture. This picture is a young boy with cystic fibrosis. He underwent a combined transplantation. You observe here the scar of the double lung transplantation using a double anterolateral thoracotomy, so a mini-invasive approach. And also you can observe in the abdomen the liver transplantation. So this boy underwent lung and liver transplantation combined in the same day, 18 hours anesthesia. And at the end of the surgery, this patient was extubated in the OR. So this kind of patient are able to be extubated in the OR with a very good result and a very good outcome. It was published 3 times by our team, only in cystic fibrosis by Marie-Louise Felten in BGA, then in the emphysema population, and then in the entire population. And everything is thanks to how it was explained earlier, by the commitment of the whole team, the surgical team, the anesthesiology team, the ICU, the nurse, the physiotherapist, the pulmonologist, to go into this enhanced recovery after lung transplantation. So it's a work that has started since the preparation to the patient to the surgery, to the journey of the surgery, and then after the surgery. And again, so about the study on the OR extubation in the entire cohort, you see the difference in survival, not because extubating a patient is something good, but this because you can assess that there are some people that can be de-escalate, and we can go more in a fast track journey postoperatively. And it is safe because from the 400 patient in the cohort, we had only to reintubate 4 patients due to technical issues. Okay, but then that is possible, as if you remember the first graphs, if you assess the patient at the end of the surgery, where you have this idea of how is going the honeymoon between the graft and the host. So either the patient is under ECMO or not, do we need it? And we have to ask the question every time at the end of the surgery. Do we need the ECMO? Do we need to maintain inhaled nitric oxide? That's our strategy. But also, do we need to maintain invasive mechanical ventilation and then remove everything? Well, just to highlight that it was already published, enhanced recovery after liver transplantation was already published as a recommendation by the International Liver Transplantation Society last year. Maybe we should do something similar because we start having some interesting data in literature. So to conclude, enhanced recovery is at the crossroad of thoracic in lung transplantation, at the crossroad of thoracic and cardiac surgery. We have to propose that to every patient, but then tailor the evolution depending on how the lung transplantation is going and how the patient is reacting. I mean, everything is thanks to the multidisciplinary team and including the patient in the team, and to push the boundaries and do great things such as remove a tube at the end of a lung transplantation in the OR. Thank you very much.
Thank you, Julian. And I would also thank all the presenters for staying in time. So we have now time for about 15 minutes for panel discussion. And I would just encourage people to post their questions in the chat. And first of all, I would like to start with some of these questions who reach me directly or want to have been seen by everybody. So we've heard about pre-op optimization in terms of nutritional factors. So there are patients with who are let's say overnutrition and some that are undernutrition, and questions here are regarded to this. So are feeding tubes used to bring patients into a better state? And maybe Kevin, you can comment on that. Do you think this is in advanced heart and lung failure surgery, this is a good concept to place feeding tubes before surgery, or what's your perspective here?
That's a good question, Alexander. Let me digress for just a second and thank Evaldis, Alex, Igor, Constance, Julian, and all the speakers for their great talks. I think what we're really hearing is people that work in high-performance organizations, which are marked by common aspirational goals, alignment, and holding people accountable. We heard that in a lot of different ways, but I think that's the tie that binds. And what this requires is leadership and interdisciplinary teamwork, right? The essentials of enhanced recoveries. So with that in mind, I'd be the first to say with respect to prehabilitation, we have less data, more prehabilitation efforts in countries that seem to have waiting lists. We have much less of that, at least in our area in the United States. So then when you start to look at the individual elements of things like nutrition and its effects, I think you'd have to look at things like esophageal cancer, right, as one example of that historically, of a malnourished patient and how they benefit. So the point being, yes, it can help. Now we probably need to look at some of the more malnourished heart and lung failure patients, specifically, those that have been catabolic and are frail or wasted from a protein standpoint. But let me make sure that I'm clear. I don't think we have clear evidence documenting the value of that in that specific group right now, but it makes common sense that we should pursue that in whatever means are most valuable.
So, and maybe, of course,
Kevin, maybe just a little question, and maybe also to Evaldas. Do we have experience in non-transplant, non-vet patients on additional nutrition and maybe, very sick patients of feeding them with a tube or something like that?
Yeah, if I'm interpreting the question and your response, Herman, I would agree. I think there's great opportunity to optimize and tune these. If you have good evidence, showing that, I think that's important to get out, because I don't know that everybody is doing it or certainly aware of it. Christian Stope, has been a big proponent, really interested in this, joining forces and growing efforts through ERAS in Europe. But Herman, whatever you have and others that can help support this, we should try to get that out. Maybe that's a separate segment. Maybe we do a preoperative optimization and we focus on these key things like nutrition.
Evaldas, what's your opinion?
I think personally there is probably a proportion of patients that would benefit from that. I mean, it's not a real elective minimally invasive valve surgery patient, mostly not really need no specific address on nutrition facts. But if you think of expanding this indications towards advanced heart failure patients, in particular, severe comorbidity associated patients, undergoing high risk surgery. So this is probably the population of patients who would benefit most of them. But I think it's not, as already Kevin mentioned, there is no real good evidence to support that at the moment. So I think it's still done on an individual basis and needs an interprofessional assessment of the patient before the surgery.
So maybe I can pass the question over to Igor and Katie. So you already implemented a ERAS protocol in LVAD surgery here. What are the limitations? Evgeny, for example, showed us cardiogenic shock patients, so acute decompensated patients, and is doing surgery under local anesthesia. But where are the limitations? So is it an all-comer approach, or is it only for selected patients?
Yeah, so again, I'd like to just echo Dr. Lovedell and thank everybody for their presentations. These were absolutely outstanding. In regards to your question, Alex, we actually use an all-comer approach. So really any patient who comes through our program is placed on the pathway, and the opportunity to optimize them preoperatively as well as to standardize that care intraoperatively and postoperatively allows the entire team to recognize when a patient falls off the standard pathway or what we expect to be the standard pathway. Of course, there are certain patients who enter who are maybe more critically ill or perhaps more malnourished, as we were just discussing, and that might affect the timing of when we take them to surgery. It might affect some more specifics of workup or the way that we handle the patient postoperatively or communicate with our team postoperatively about anticipated recovery. But ultimately, the idea is that by standardizing the entire care pathway, anybody on the team can notice when we're either missing a step or the patient has some unexpected change in their trajectory. And it allows us to intervene on those and work those patients up a little bit sooner and find and recapture them rather before they've really turned down.
Yeah. And Evgeny, so do you go for, is every patient who is not intubated, is every patient a candidate for this local anesthesia approach for short-term devices?
Yeah, it is. We go in the OR and I see the patient and I tell him about local anesthesia, but very important is a discussion with the anesthesiologist, because it's finally his decision to do nothing or to perform anesthesia, narcosis, because those patients, especially patients in severe cardiogenic shock, they are very difficult to keep calm on the operating table in supine position. So and they deteriorate fast. So if you start to implant Impella, it takes approximately 40 minutes, 30 to 40 minutes to have Impella in. And in the beginning, it's maybe stable patients, but in the end, it's really respiratory insufficient. The patients start to be not calm because of hypoxia. So, and you have to convert them, or a special, very, very dangerous is VT or ventricular fibrillation due to a wire in the left ventricle. So you should be prepared for all of this, and you have discussed with the anesthesiologist. And finally, it is anesthesiologist's decision to stay with local anesthesia or to intubate the patient. But again, we start with everyone, and then we decide just before or even during implantation of Impella in local anesthesia.
Thank you very much. I just one question regarding to people who already started ERAS programs here. Where do we start with ERAS? So what's the first step? Do we start with pre-op exercise? Do we start with nutrition? Do we start with early extubation? Do we start with the anesthesia? What is the first step?
Alex, this is a great question, and I know for us in Rochester that was something that we worked through as a team. We've, as a surgeons, actually had established this less invasive LVAD implantation. We were thinking about doing it off pump, and we were doing it on everyone. The same as Potapov was saying, everybody comes to the OR are getting the same surgery. And that really helps the throughput, and that really helps our team in the OR understand what we're doing. We expanded that to our anesthesiologists. It's like it grew like a bubble. Anesthesiologists, ICU, nursing, floor, but it really is critically important that everyone's involved.
I have one question, one comment to Igor. It's a critical comment, but we have to discuss this point also. And I discussed it with my team, because if the patient, for example, is on the table hypoxic, moving continuously, so I cannot perform very good anastomosis in this situation. So this is a limitation. And I just opened the paper published by Igor last year, or this year, the 2024 comparison of minimal invasive compared to full sternotomy. And I just read this paper, and I found that the minimal invasive total implantation time is 6.5 hours. And sternotomy 4 hours 44 minutes, so at most 2 hours longer. So this is a point of discussion. This minimal invasive implantation or this local anesthesia should not be longer or more invasive for the patient because of time, but you want to do it in the local. So if I see that the situation goes in the wrong direction, I stop the surgery, and we converted 2 patients, and then we continue in the stable position. So it should not be just because of should be minimal invasive, but takes longer, or it is more harm for the patient.
I agree with you.
So we are coming. Igor, sorry.
Oh, yeah.
Sorry. We are running. We're going to the end of the session, and Evaldas and Alex raised their hands. So I would first give Evaldas the time, and then Alex and Hannah has also just a minute, and then we have to wrap up, unfortunately. And then yeah.
Alex, thank you very much. Very, very brief comment from my side regarding where to start with the ERAS program. So I think the extremely important point is to identify, the most important players in your team. And there's no general, recept for this to collect a bundle of the steps and measures involved in your project. I think it's extremely important to identify a team and define your own protocol where you want to start with. And the most important thing, not to try to start with the most sickest patient at the beginning. Thank you.
Thank you, Alex.
Yeah, thanks. I was going to mention something similar. I think the quickest way to fail is if you do a protocol that hasn't been bought into by all stakeholders, or a protocol that doesn't tackle the main issues that you have in your own institution. So I think what you need to do is take the elements that exist in guidelines or what other people have published or what other people are doing, sit down with your stakeholder group, ideally get some data before you sit down that identifies the areas of weakness in your institution, and then pick the top 10 or 12 elements you want to start with that tackle that low-hanging fruit, and that will optimize your chances of success.
Thank you for these excellent comments. Hannah.
Hi, thank you, Alex, and thank you for the opportunity to be here to everyone. I think there's a few things that are low-hanging fruit that apply to all patients regardless in cardiac surgery. One is minimizing narcotics. Sternotomy incision is a sternotomy incision is a sternotomy incision, right? The narcotics don't increase because it's a sternotomy incision. So I think you can create a protocol that's successful to minimize narcotics no matter where you are. That is, though, as Alex Greger just said, buy-in by the nursing staff to really understand minimization of narcotics. But we have an opioid epidemic in the US, and so that also becomes a social responsibility that's important to think about. The other thing is nutrition. And, I think I took Kevin's approach with nutrition in regards to patients that it's logical, right? So even if I have a cachectic patient who, I did a dissection on, they're going to get tube feeds afterwards, and we're going to do everything we can if we're doing nocturnal tube feeds, letting them eat during the day. And so it's not something that applies specifically to transplant bad patients, but it's all across. So an early mobilization, working with physical therapy to really move these patients afterwards. So I think those are three things post-operatively that surgeons can focus on regardless of the program and where you are. Now, you do need buy-in, and it takes talking to the nurses in the ICU, nurses in your progressive care unit, and then your physical therapists, right? But every program can minimize narcotics, can early mobilize, and maximize on nutrition to start. I think Katie had asked to talk about the minimal narcotics. So we published a few years ago where we did a Likert scale comparing traditional narcotic pain meds to then a protocol that minimized narcotics, where we have acetaminophen, gabapentin, lidoderm patches, and tramadol. And every patient, regardless of scheduled case for CABG, aortic dissection, transplant bad, got that protocol. And what we demonstrated was that there was no increased pain requirements or needs of those patients, that they actually had equivalent or better pain control in that study for all comers. And so it's really about a setup. All these patients, the one thing of bad in transplant patients, you do have the opportunity to talk to them before the surgery. And so all patients are prepped with the same mantra of minimal narcotics and the benefits of minimal narcotics, decreasing delirium, decreasing confusion, GI, and postoperative events. But I also tell every patient, surgery is not without pain. You will have a reasonable amount of pain so that you can deep breathe, talk, and mobilize. And I said, that has to be a realistic expectation. I think surgeons have to reset and course correct the bar. I think especially in the US, that life is pain-free. And it's on to us to tell the patients that. So I think those are the low-hanging fruit that every program can start with, but it does involve active communication with the nursing staff, PT, and your dietary programs to get those. I think those are the three elements that one can easily start with.
Thank you, Hannah. And maybe Katie and Herman with the last words, and then we have to wrap up.
Yeah, basically it's just a very brief comment to Julian, because we didn't have much of him in the discussion. You know, very important for ERAS is, of course, prehabilitation. We know how sick lung patients are before surgery. Can you briefly comment on your idea of prehabilitation for lung transplant patients?
Yeah, thank you. Thank you very much for this question. Well, it's more complex, and I think that we have to just take the recipes from the other societies for the elective surgery, and even as if these patients are really sick, we can maybe improve them, put them again to do exercise, because sometimes some patients don't do exercise at home, never, and because they are now getting into a transplant program, they get the motivation, and motivation is going through the physiotherapist and the physical physician to help them to adapt an exercise to their capacity, then to motivate them, then also to take into account the psychology and maybe the anxiety and depression. So rehabilitation is a really well written program, and we just need to try to adapt on what every patient it's able to do, and then and see what's happening. But really, we need more studies to test how these kind of programs that already exist are able to be implemented. That we do. We send our patient to specific centers for rehabilitation, and then the patient arrives with 10 kilos more, with more strength, with a better functional capacity. We have to take care of the anemia, especially in cystic fibrosis. Even if these patients, we don't see them anymore as much, but we'll see them in some years. So that's the global program, and I believe that we have to put all the patients in an ERAS program. Going to an OR extubation is not possible to everyone, and by putting the patient to work immediately after surgery is not possible. But at least the first stage, before surgery, we can try to do it to everyone.
Thank you, Julian. And Katie?
Yeah, I'll be very brief. I just wanted to stress the additional importance and go back to that initial question of how do we implement this successfully? And all of the comments were obviously spot on, and the importance of buy-in from the team and the staff. I also wanted to really stress the importance of patient engagement that was part of this process. Getting patient buy-in is really what makes this successful, and being able to start that process on the front end with the patient and their families through education and setting expectations, and continuing that through the entire hospitalization ultimately really allows that buy-in that you already established with your team to take full effect.
Yeah, thank you very much to all presenters, all panelists. I think we are at the beginning of a journey, ERAS in advanced heart and lung failure surgery. It was incredible, and thank you very much for attending. And I'm really looking forward to see you all at the next annual meeting in Boston.